New research into gunshot wounds in Ontario has started an important conversation about mental health in Canada's rural communities. A study in the Canadian Medical Association Journal found that more than 2/3 of gun-related deaths in Ontario are suicides, and the majority of those deaths are older men living in rural areas. Dr. David Gomez is a trauma and acute care surgeon at St. Michael's Hospital in Toronto and the lead author of this study. Doctor, good morning.
Oh, good morning, Matt. Thanks for having me.
Thank you for joining us. This is important. Why are older men in rural communities so much more likely to die by suicide from a gunshot wound?
Well, I think this is, like every difficult problem, is quite multifactorial. One big aspect of this that I hope your listeners take away from this is that there's a significant lack of access to mental health resources in rural communities. Primary care practitioners already have so much on their plate, and they don't really have the resources to screen these men at risk. And if they happen to identify someone who's at risk of injuring themselves or others, the resources to actually intervene are not there.
It's interesting because we often hear of gun injuries or gun violence, and people perhaps might think of big cities and think of gangs. Does this research that comes out of this study force us to rethink that?
I completely agree. I think we have two big problems in Ontario, and likely we're able to extrapolate this to the rest of Canada. Downtown Toronto, downtown Hamilton, the GTA has a problem with assault-related injuries, and they happen in a very specific subgroup, young men living in the neighborhoods within the lowest socioeconomic status. However, most of the deaths, as you said, occur in men 45 or older. 96% of self-harm-related injuries occurred in men, and communities that are classified as rural were significantly overrepresented. And as you said, that's not what the average Canadian thinks when they think of a firearm injury. However, that's how your community is most likely to be touched by firearm injury. It's going to be suicide.
You're a trauma surgeon in Toronto, so tell me a bit more about that. What have you experienced yourself when it comes to dealing with gun violence?
Man, unfortunately, firearm injuries are our day-to-day. Either I'm taking care of patients in the hospital that have devastating consequences of their injuries. I see them in the emergency department almost every day. I see them in my clinic while they're trying to recover, not only physically, but also emotionally, financially, from the impacts to their families. When I talk to my colleagues, coroners who work in rural areas, suicide is their day-to-day, having to drive out to the family farm to find, unfortunately, another victim of firearm-related suicide. And our data shows that every 3 days in Ontario, there is an injury or death secondary to self-harm.
Every 3 days?
Every 3 days, somebody is either getting injured or dying by a firearm with the intent of self-harm.
And again, this is a study about Ontario, but what is your sense as to what we would know about the demographics of gun violence in the rest of the country?
I think one key thing that's important from this is that scientists such as myself need the tools to be able to answer these important questions. I don't know if this distribution is the same in the rest of Canada because the data is not there.
There are a couple of different tracks here to explore in terms of how to address this. Your study is calling for better suicide prevention strategies. What specifically needs to happen?
Matt, the way I address this as a scientist is I try to generate as much facts possible for mental health experts and legislators to enact change. And when we look at violence, we have to look at it like a disease. So there's a host, the person that's experiencing the violence, there's the environment in which they live in, and then there's the vector, which is the firearm. And I think there's a wealth of international evidence showing that if you decrease the number of firearms available, you will decrease the number of violent events related to them, including suicide. However, firearms are part of the culture and the day-to-day of a lot of rural Ontario and Indigenous communities. So we have to understand that. We can't just say no more guns and then all of this problem will magically disappear. We have to encourage safe storage. We have to encourage storing your firearms separate from your ammunition. When you look at the host, the person who's experiencing this, we have to be able to first identify people who are at risk and then intervene. But we have to generate programs that make sense for where you're trying to establish them. So if we try to generate a program that's going to work in downtown Toronto, it's not going to work in Thunder Bay. So we need to generate big partnerships with urban, suburban, and rural practitioners to be able to first identify and generate interventions that actually make sense to the average rural male.
There's a humility in that, in saying that, yes, as a surgeon in downtown Toronto, you can't just go and say, no more guns, or that the solution that works best for you in an urban setting is going to work, for somebody who happens to be in a rural community. Tell me more about the importance of that and understanding that it's not, as they say, a one-size-fits-all kind of solution.
No, 100%. There's a large number of examples in medicine and society that have required large societal changes to improve our health. Asbestos is a perfect example. A large community required or had their livelihood secondary to asbestos, and we have to completely eliminate that because of the significant health impacts of asbestos. Motor vehicle collisions are the same. We completely redesign cars, roads, our legislation, our behavior in order to reduce the risk of being injured or dying from motor vehicle collisions. And the same thing needs to happen with firearms. We have to first identify and accept as a society that we have a problem. And then this requires, as I said, large societal change, legislative changes, and behavioral changes from the everyday Canadian.
One of the things that people talk about is sort of so-called red flag laws. What are those?
So in a variety of different settings, some states down south have laws that allow primary care practitioners, emergency department physicians that might identify people that are at risk to themselves or others to be first identified, and then the authorities notified. So if they own a firearm, they can be temporarily restricted access to these firearms, so to try to reduce the risk of them injuring themselves or others. And this has been proven quite effective in a variety of areas. And as I said, we have to give the people in the front lines first access to these resources so we can impact some change, but also the vast majority of firearm owners in this country are responsible, and they have to have trust in the strategies that we're going to generate. So partnerships are important.
Those partnerships are important, again, just finally, because you can imagine that there are some people who would hear some of those legislative controls you talking about further gun restrictions and say that things that you're calling on would infringe on what they believe is their right to have a gun.
I completely agree, and I understand what they're thinking. But whenever I hear something like this, it brings me back to whenever the seatbelt laws first came out, and they were protests against seatbelts as they were infringing on their rights. As we see anti-masker protests because we're infringing on their rights. I think my role as a scientist is to provide public health experts, mental health experts, legislators with the facts needed, show who's at risk, and then try to generate legislation that is going to provide the greater good for society.
Dr. Gomez, good to speak with you about this. Thank you.
Thank you very much.
Dr. David Gomez, a trauma surgeon at St. Michael's Hospital in Toronto and the lead author of this study. If you or someone you know is in distress, this is the number for the Canada Suicide Prevention Service. It's 1-833-456-4566. You can text at 45645, or you can go to their website to chat. It's crisisservicescanada.ca. Dr. Allison Crawford is the medical director of the Ontario Psychiatric Outreach Program with the Centre for Addiction and Mental Health, also the chief medical officer of the Canadian Suicide Prevention Service. Dr. Crawford, good morning to you.
Good morning, Matt.
When you take a look at this study, what does it tell you broadly about the state of mental health for men in rural areas?
Well, I think as Dr. Gomez really expertly outlined, I think it's really important data because it does reveal quite a significant public health risk that's associated with the availability and the prevalence of firearms. And also, as he pointed out, we have to think right along a continuum of interventions, from prevention all the way to intervention, to combat this problem.
What's missing in order to connect older men in rural areas to mental health services? We know that, and we can talk about stigma. Stigma exists across the spectrum when it comes to mental health services. But what specifically is going on with these men 45 and older in these rural communities?
I think we need to understand more. I mean, I would like to see more research that aligns with this, getting the perspective of men in that age group and hearing about their lived experience, particularly men who have experienced thoughts of suicide. And then again, I think we need a public health approach that's coordinated. Not just, when we say mental health, we don't just think of psychiatrists, but most immediately, this study calls for us to think about access to firearms, whether it's legislative, and just having people aware that having a firearm in their home creates an increased risk, a 5-fold increase risk for self-injury and suicide. And so to have those kinds of programs that were talked about, like safe storage programs, red flag programs, and having people who are in primary care, I think, is another vantage point to try to engage these men. Training people in primary care, they use that strategy in Quebec very successfully to know that these men are at particular risk and how to do assessments. I think that there are challenges around access to psychiatry in the North. We know that there are far fewer psychiatrists in Northern Ontario than in Toronto or other major centres. So addressing that and looking at innovative models where psychiatrists support primary care rather than needing a psychiatrist to necessarily see every person. But most importantly, I think also knowing what works for these men. That's been touched on. Looking at ways to intervene that are culturally relevant to this group of men, that are strengths-based. One of the things I did want to highlight, I was so glad you read out the number for the crisis line, but that suicide can be prevented, and that this group of men obviously has lots of strengths that can be tapped into as well.
Let's talk about one of those programs. I want to bring in another voice into the conversation here. Bill Farley started a local chapter of the Mensheds program in Dauphin, Manitoba in 2017. He lives in Minnedosa. Bill Farley, good morning to you.
Good morning, Matt.
What is Mensheds?
Menshhed was started in Australia back in 2007 because of suicides with older men. And the word shed is an analogy for the average guy who has a shed in his backyard and does, any kind of repair work, woodworking, stuff like that. Yeah. So that was taken as the analogy for the word shed. So Menshed is an organization that will work with older men who have not only contemplated suicide but are in depression or whatever. And it's an opportunity for fellas to get together and do various kinds of projects, like woodworking seems to be the main one, but there's lots of other stuff. And to give back to the community. So we do a lot of work with nonprofits and other organizations that require repair work or require something to be built for them, whatever.
And as you mentioned, this is in part about addressing issues of depression. When you launched this and you held your first meeting, tell me a little bit about what happened. Who came to the meeting?
Well, there was a workup before that. I had a lot of posters around town and radio spots and stuff. And eventually the meeting time came. I had never heard a word from anybody. So I didn't know what was going to happen. But all of a sudden, 35 men showed up, all in the range of 60 to 80 years old. I'm 86 myself. And I explained to them what we wanted to do, and they were quite enthusiastic, and it just took off from there. I'd like to just go back a little bit. I called for an information meeting at the local senior center. And again, I had posters up and everything else. And when I went to speak, there were 50 women there, no men.
Why do you think that was the case?
Well, a lot of the data I've seen, older men just do not want to get involved in programs that senior centers put on for some reason. The director of the senior center in Dauphin has been trying for years to get older men involved, and it just didn't happen.
Allison Crawford, how do you address that? And part of it is about, to Bill's point, men going to maybe a senior center, but it's also about men maybe not wanting to sit around and talk about how they feel. Again, that goes back to the issue of the stigma. How do you address something like that?
Yeah, I think it reminds me of, I've heard it described as men do better shoulder to shoulder than face to face. So sitting in a clinic is maybe not the right approach. And I think the kinds of things that Bill is doing is exactly that, reaching out, letting men know that it's available and normalizing it. And I think that reduces the stigma. I think social connection is such a protective factor against depression and suicide.
What do you hear, Bill, from the men who come and they're part of the program? What do you hear from them about why they're there?
Well, if they have a partner at home, that's a fairly large factor. When I completed my talk with these women, they were quite enthusiastic because they said that's an opportunity to get old George off the couch and out of the house. So I think that was one of the factors. Their wives literally dragged them there. Secondly, I need to back up a bit. We're talking a rural area, sort of central Manitoba. And so most of the fellows I worked with had come off farms. They'd sold the farm or they'd given it to their sons to run, and they moved into town. And that's when it all started for them. They had nothing to do. And what I've learned is that men get their sense of worth from their occupation, whatever they're doing. It doesn't matter if they get their worth and they're seen as being worthwhile. That seems to keep them going from day to day. So the fellows I worked with were there because they saw an opportunity to give back to the community and feel worthwhile, to be doing something. And just to respond to a previous remark, the idea of talking about feelings and sharing personal happenings in their lives, that will come later as these fellows get to know each other and have they just won't talk if they don't know each other.
Allison,
I'm 86 years old. I come out of an era where men just suck it up and don't talk about feelings, and so that's what I was dealing with.
But as you say, if you can get people to know each other, then they're going to be more likely to be able to speak openly in that way, if they feel comfortable.
Exactly.
Allison, just finally, what gives you hope when you hear about a program like the one that Bill is involved in?
Oh, I think Bill's observations are so important. They're the kind of observations we don't necessarily get to spend time with people like that in psychiatric practice, and I think it's so insightful. I also think that starting when I hear the age of these men, upstream approaches that start when boys and men are younger and encourage social connection, I think are also really important to lay the roots for that kind of social connectedness. But I think it's incredible work. I think it needs to be, if it works, it needs to be implemented more systematically.
Bill, thank you very much. And Dr. Crawford, thank you so much.
You're welcome.
Dr. Allison Crawford is the medical director of the Ontario Psychiatric Outreach Program with the Centre for Addiction and Mental Health. Bill Farley started a chapter of the Mensheds program in Dauphin, Manitoba. If you or someone you know is in distress, this is the number for the Canada Suicide Prevention Service. It's 1-833-456-4566. You can text at 45645, or you can go to their website to chat. It's crisisservicescanada.ca.